Right, thanks again. And Christy, I really enjoyed your talk. And it's a very nice opportunity to segue to this particular talk, which is part two, emphasizing the question, what's the goal? So the title of the talk today, Making a Difference, Are We? I borrowed from the theme of the 2016 annual meeting of the ACP-GMEM that I had the pleasure of hosting in Hollywood. I was the incoming president at the time, and we chose this theme to ask the big question about that we should be posing to all of us in our presentations. So in this part two, I'd like to address what the priorities of ambulatory children with cerebral palsy are, what the limitations of the current outcome measures that are being used for this spectrum of kids with cerebral palsy, and share with you the development of a new outcome measure, which is the GAIT Outcomes Assessment List, or the GOAL, and end with this part, which is what's in it for the patient or parent? You know, how are these outcome measures of any value to those who are actually completing them? So I'm introduce you to David again. You'll recall that he, like Jill, is 12 years old. He's a twin, and his twin brother does not have cerebral palsy. He functions at a GMFM level 3. He walks with canes at home. He's using a walker at school in the community. I mentioned to you that his parents are very proud that he's not using a wheelchair. If you actually speak to David, he is not so fussed about that. He would, you know, he wants to just go out more, be with his friends, and while his brother is out with his friends, David's doing spending a lot of time doing therapy, and you know, he feels somewhat excluded. He's been less active over the last year, and his parents have expressed a goal of wanting him to walk better. Okay, so David walks on his tiptoes. His feet are turned in. His knees are flexed and they're rubbing against each other. He trips frequently. He tires easily. He has some knee pain. As I mentioned, he finds it difficult to keep up with his friends, and he's relying more on a walker, even indoors. And he undergoes a 3D gait analysis and is recommended multi-level orthopedic surgery to improve his gait. So the surgery happens 6 months after his operation and extensive physio. He now walks with his heels down. His feet are pointing straight forward. He's standing taller. The knees come to full extension during stance phase. He's no longer tripping. His knee pain is resolved. He's still using a walker at home and at school, and is now having to use a wheelchair outdoors. Remember, before his operation, he was using a walker, which he hadn't had to use previously, and he hadn't used a wheelchair previously. He's also experiencing hypersensitivity in his feet, and he uses air for support. Now, his walking speed and endurance declined in the first few months after surgery, but in the last month or so, they've improved sufficiently to come to sort of his pre-op baseline, but has not exceeded his preoperative level. So the question is, has the intervention made him better? And how do we find out? So remember, I talked about Michael Goldberg, who would look at this in the context of a technical outcome, where we'd say the goals of our multi-level surgery is to optimize the biomechanics and the lever arm dysfunction. So we're increasing the contracted muscle lengths to improve the range of motion. We're correcting the bony deformities that were responsible for the increased anteversion that caused his feet to turn in and his knees to rub against each other, by addressing his hamstring length. Maybe we got him to stand up straighter and take the pressure off his kneecaps and reduce his knee pain there. And by getting his feet down, by addressing the gastroc contractures, allowing him to trip less and give him more stability. But Mike Goldberg would say, well, why did you do the operation? What were the functional reasons for doing it? Well, maybe it's to help him walk further, to walk faster, to relieve pain, to make him less tired, to reduce his tripping, eliminate his falls, improve his gait appearance. And, the surgery can be preventive to prevent bad things from happening in the future, or reactive to address the problems that David was experiencing at the time and expressed an interest to have addressed. We've heard about the ICF framework quite a bit. And in David's case, at the level of the body structure, there is the hypertonia from the upper motor neuron lesion in the brain, resulting in decreased motion, which is the body function or range of motion due to the dynamic and static contractures. And then again, at the level of the structure, he's got these torsional deformities. And these are limiting his ability to, let's say, walk or run. That's the activity limitations. And, what's the purpose of walking and running? Well, it could be to allow you to be independent. It could be allow you to play sports, to go dancing, attend school, keep up with friends, and so on. And there are environmental and personal factors that can help you do these things even without walking and running. So the walker can be very helpful. So can a wheelchair to get you from A to B, but you have to have an environment that allows you to use that wheelchair in terms of being accessible. And then there's the personal factors. David might turn around and say, look, I don't care about the way I walk. I just want to be able to go out more. And if I have to do it by a wheelchair, that's perfectly acceptable to me. And who are we to judge whether that's appropriate or not? I choose to drive to work. I could walk. It would take me, an hour and a half to do so. We press a button to take an elevator, 10 flights of stairs, to avoid taking 10 flights of stairs. So these are technologies that we can use to be more efficient, and a wheelchair should be seen as perhaps just another piece of technology. So when we think about outcomes after any treatment, there are three possible outcomes. After an intervention, there can be a positive change, either overall or in some domain, and that we would call as a benefit. There could be a negative change, either overall or in some domain, which we would call a deterioration. And you could have a bit of both. You could have benefits in some domains and deteriorations in others. Or you could have no change at all. And when you detect no change, that could mean one of several things. It could be that the intervention did not work. It could be that whatever you're using to measure the effect of that intervention, namely the outcome measure or tool or instrument, is not sensitive to pick up a change, even though change has actually occurred. So it's not responsive. Or it could be that no changes has happened because you don't expect a change, but the intervention has actually been very successful because it has prevented something bad from happening in the future. So it is prophylactic or preventative in its intent, under which circumstances you wouldn't expect to see some sort of functional gain. So we shouldn't dismiss that as not being important. Or it could be a combination of these three things. And we would not know unless we had validated outcome measures that we knew were sensitive to change when change do occur, to make judgments about whether it's the intervention not working or it's a problem with the instrument. So let's review what outcome measures we have for ambulatory cerebral palsy. Well, we've heard about GAIT analysis. So this is in the motion lab. You have a bunch of cameras that can capture your motion in 3 dimensions and space, from the side, from the top, from the front and back. And it's really measuring your impairment at the level of the body function. There are ways of quantifying it. We'll talk about that in a little bit more detail. There's the gross motor function measure, which is also a measure of impairment of bodily function. There's the pediatric outcomes data collection instrument, the PODCI. These are patient-reported or parent-reported outcome measures. There's the activity scale for kids. These are generic measures. There are more condition-specific measures like the FAQ from GILLETTE and the functional mobility scale from Melbourne, and there are a whole bunch of computer adaptive tests like the PDCAT and the PROMIS. So there's lots of really well-established measures that have a lot of utility for this particular population. So let's look at them one by one. So the GAIT analysis is really the best objective measure of the impairment. It measures GAIT parameters like the walking speed and the length of a step or a stride. The kinematics is the technical term for measuring the range of motion during walking of every limb segment in 3 dimensions. So how much the thigh segment moves, or the lower leg segment moves, or the foot and ankle relative to other joints. The kinetics is the moments and the powers, which also describes a more detailed biomechanics of the gait. You can evaluate which muscles are working at any given time using dynamic electromyography. You can measure how much oxygen is consumed or the energy expenditure during walking. So this is an incredibly powerful set of tools in a motion lab. And these can be used for decision making. These can be used obviously as a measure of outcomes as well. And in the last couple of decades, there has been a move to summarizing the GAIT patterns captured by GAIT analysis in a single summary measure. There is the GILLETTE GAIT index, for example, or the GAIT deviation index, which is a derivative of the GILLETTE GAIT index. There's the movement analysis profile, or the GAIT profile score. And all of these are essentially a single number, if you will, or a single value that quantifies how different somebody's gait is from normal. So what is the deviation of gait from some definition of normal? And it's a combination of at multiple levels. It puts it all together and gives you one number. So yes, gait analysis is really the best objective measure of the impairment, but how well does the conventional gait lab actually represent or capture the real world? Remember, this is in a pretty sterile environment, very controlled. Maybe there's a walkway on level ground on a flat surface for 10 meters, where they walk up and down, being watched by a therapist and maybe coached by the parent and so on. There is very, how representative that is of real life. I would argue that in day-to-day life, when we walk, there are very few occasions we're walking in a straight line on level ground for 10 meters without encountering an obstacle or another person that we have to avoid, or that we have to turn left, or avoid a step, or go up some steps, etc. And so we have to recognize that gait analysis, or what we're seeing in the GAIT lab, is just a very, very, very small piece of the puzzle. And how valid are these summary measures? This single number captures a lot of information, but how valid are they and how representative are they? They're all weighted equally, and is that the appropriate way to do this? And how are these summary measures correlate with actual patient or parent perception of the outcomes? And has any work been done with that regard? One of the most well-established measures is the gross motor function measure, the GMFM. There's the version 88 and more recently the version 66. That is a physiotherapist assessment of the gross motor function skills, and I imagine there's a lot of you in the audience who are intimately familiar with this very, very tool, this excellent tool that has 5 dimensions of lying and rolling, sitting, crawling and kneeling, dimension D, standing, and then of course dimension E, walking, running and jumping. These are sort of the gross motor skills. And it takes about an hour to do, where a child is observed in each of these dimensions and is scored from 0 to 100. It's a well-validated measure that's been widely used even in clinical trials. And however, it has its limitations. It's measuring capacity or capability rather than what actually happens in real life. Again, this is in a controlled environment, and it tells us what a child can do, but not necessarily what a child does do in real life. But it's still incredibly useful and powerful. But let's dig a little bit deeper. We know from the wonderful work out of Canchild in McMaster, the same group that gave us the GMFM and also the GMFCS level, have looked longitudinally in a population cohort of children with, as they grew older, what their GMFM scores were over time. And what their work showed was that all children with cerebral palsy make improvements in gross motor function in the first 5 to 7 years of life before they plateau. And of course, they plateau at different levels, which roughly are equivalent to the GMFCS levels, where level 1's plateau at the highest and level 5 at this level here. So if we recognize that all these children are making gains, even when they are not subjected to any intervention. So during this time span between 0 to 6 and 7, if we subject them to an intervention and we see a positive change, how can we be sure that that change is not due to the natural history? How can we be sure that we can attribute it to the intervention it is? The only way we can do that is if we have a control group who did not receive the intervention, compared to which the slopes of these changes are different. On the other hand, as children get older, these don't stay static. As they reach adolescence and go through puberty, there is a somewhat of a decline in the gross motor function scores as they get bigger and heavier, or perhaps by choice are relying on more significant aids, and there are declines for levels even 2, 3, and 4. So for this population, you could subject them to an intervention, and if they did not change, we should not necessarily condemn that or dismiss that as an unimportant effect, because it's conceivable that without that intervention, they may have deteriorated. But once again, we would not know that unless we had a control group to make that distinction. The point of this slide is to understand that through natural history, some of our outcomes may actually change naturally, either in a positive direction or a negative direction, which speaks to the importance of having control groups and comparative studies with clinical trials or even observational studies to be sure that the changes, either positive or negative, can be attributed to the intervention or due to the natural history. So let's look at the GMFM. It's been used in many, many clinical trials. In fact, the first time I learned of Jeff McLaughlin was his landmark randomized trial on SDR. It was done sort of concurrently with 2 other randomized trials, one in Vancouver, one in Toronto. Of the 3 studies, this was when I was doing my clinical epidemiology degree. During my systematic review and meta-analysis course, I chose to do a meta-analysis on this. And I even presented at AACPDM, but I was beaten to the punch by Jeff's work in publishing their meta-analysis of the 3 studies. But in my looking at the 3 studies, it became very evident that not only was the GMFM the common outcome measure used in all 3 studies, but it was the methodology was very similar. But of the 3 studies, the SDR trial in Seattle was the best of the 3 studies. The follow-up was until 2 years. It was a much larger sample size, and the rigor was much greater because the control group was intensive physiotherapy, the same intensive physiotherapy that the SDR group received as well after their surgery. Whereas in Toronto and Vancouver, they got sort of usual physiotherapy compared to, in the experimental group, they got SDR and intensive physiotherapy. And not surprisingly, the benefits of SDR were greater in the Vancouver and Toronto trial, whereas in the Seattle trial, there was no difference between the 2 groups. And I would say that is the more rigorous of the 3 trials because it was a fair comparison. So it's possible that the increased benefits of SDR in Toronto and Vancouver could be attributed to the additional co-intervention of the intensive physiotherapy. In a single event multi-level surgery that Christy mentioned is sort of our philosophy in orthopedic surgery for gait improvements in kids with ambulatory CP. A pilot randomized trial done by Kirk Graham's group in Melbourne looked at the GMFM and other outcome measures. When they looked at the trial, the green is the SEMLS group and the darker green is the control group. These are their scores as baseline. They're very similar. This is looking at the GILLETTE GAIT index. So this is one of those summary GAIT indices. And you can see at 12 months, the operative group, their scores decreased, which means that the deviation from abnormal decreased. In other words, their GAIT appearance or the deformity of the or the deviation from normal GAIT decreased substantially in the operative group compared to the control group. And that was sustained or even improved a little bit further at 24 months. Okay, so that seems very encouraging. However, when they looked at the GMFM 66, which is again a measure of the functional effects of those interventions, those changes at 12 months were modest at best. In the SEMLS group, you know, they had a slight improvement that maybe improved a little bit more at 24 months, which was beyond the minimal clinically important difference. But you can see, in contrast to the GAIT appearance captured by the GAIT index, it's a much more modest, change. Okay. So we have to be cognizant that the GMFM, while is sensitive to change, the changes are modest, and they may or may not correspond to performance. It's more of a capability change. And again, we do not know how that corresponds to what patients actually want. When we look at other generic measures of physical function, there's the pediatric outcomes data collection instrument that Mike Goldberg and his team were greatly responsible for the development of. There's the activity scale for kids by Nancy Young and a group here in Toronto. These are generic measures of activities and participation that are included, but many condition-specific goals for this population are missing. There are CP condition-specific measures that are GAIT-related, like the GILLETTE Functional Assessment Questionnaire, which is really at its core a 10-level ordinal scale of increasing walking abilities with 22 additional skills. And there's the Functional Mobility Scale from Melbourne that I'll mention in a minute. So here in the Functional Mobility Scale, for 3 environments, 5 meters, which equates to functioning at the home, 50 meters, which equates to sort of getting around at the school, and 500 meters, which equates to getting around in the community. The parent or the child or someone else can rate how the child is getting on in those 3 environments from a score of 6 to 1, where 6 is independent. So they get a score of 6 if they were walking without any walking aids for 5 meters, 50 or 500 meters. So it's possible that they're functioning at a 6, or if they need to use a wheelchair in all 3 environments, then it's a 1, or, you know, it could be someone in GMSS level 2 is functioning at a 6 at home, a 5 in school, and perhaps a 4 in the community. So you can have various permutation combinations of this, which is very useful because it provides a little bit more granularity to the GMSCS classification. So within GMSS level 1 and within GMSS level 2 and GMSS level 3, which is a very broad category, it allows you to distinguish different children based on how much of a walking aid they want for different walking distances. And it's very elegant and very simple. When we look at the GILLETTE Functional Abilities Assessment Questionnaire, although it's been validated, it too is not very sensitive to change. Most kids may improve by 1 level or may not even improve by a level, even though they may have made big gains as measured by other measures, by gait analysis or other functional measures. So it's just not sensitive to pick up changes that may actually be meaningful. And it isn't necessarily all equate to what kids want, because it's very walking specific, but not walking related other functions. And we'll get to that in a minute. PROMIS, which is an NIH initiative of the Patient-Reported Outcome Measurement Information System, uses item response theory and has developed a number of computer adaptive tests that allow you to measure physical function mobility even for children, but has some limitations. Again, these measures are excellent for things that can be ordered, hierarchical and unidimensional. What does that mean? So something like physical function can be put in an order of a hierarchy, where at the top end, is someone who can, let's say, run as a triathlete who can run a marathon, swim a mile, and can bike 100 kilometers. Okay, and at the lower end is someone who cannot get out of bed, and in between you've got a myriad of different physical ability levels that you could order if you had enough numbers of people to test this on to see, well, on average, what is the degree of difficulty of each of those orders, and put them in some order. And so it falls within a single dimension, and you could then have an item bank of 1,000 type of physical activities that you could then create a questionnaire for that tests you on just a few items. So you would ask a question about how you do in some mid-level item, and if you could do that, you would ask questions that are of higher ability, and if you couldn't do that, you'd ask questions about some that are of a little bit lower difficulty, and allow you very precisely to put you between that low state and the highest state. So it can be incredibly efficient and quite precise. But again, it's only for those things that are hierarchical and unidimensional, and it does not work for things that equate to patient preferences. So, for example, you couldn't do this to rate your choice about your favorite food, for example. So you may like chicken. I may be vegan and vegetarian, and no one can tell me that your chicken is better than being a vegan, or a particular dish in one restaurant is better than another dish in another restaurant. These are personal preferences and do not lend themselves to being ordered in some hierarchical unidimensional way. So things that are influenced by personal preferences and choices, things that relate to quality of life and so on, don't lend themselves to these kinds of computer adaptive tests. So when you look at all of these measures that we have, and there are many, and they've been used quite widely, the one common feature is that none of these bother to actually ask children and parents what's important to them. And I discovered this because we were doing a randomized trial, a pilot randomized trial, to look at whether or not GAIT analysis, or the use of GAIT analysis prior to multi-level surgery, makes a difference to patient outcomes. And part of this trial, which was sponsored by CIHR, was to find out, well, which outcome measure do we need to use to answer this very important and controversial question. We know that GAIT analysis is very good for decision-making, it can alter decision-making, but we still don't know whether GAIT analysis, without using GAIT analysis, that your outcomes after multi-level surgery are worse. And if that is indeed the case, then perhaps institutions that no longer use GAIT analysis shouldn't be doing these operations. And we know, because of insurance reasons and so on, many institutions have lost their GAIT labs. In fact, Seattle at one point was one of them. I don't know what the current circumstances are, and there are many institutions that don't have access to a GAIT lab. So should we not be doing multi-level surgery for these kids? So it's a very important question and not an easy one to answer. And for us to know the right answer, we need to know, well, how would you actually measure what we meant by a difference? And we were going to test all these outcome measures. And this was part of our pilot trial. We did a battery of outcome measures. In the course of the trial, 2 years after the interventions, I would ask these children and their parents, do you think the operation helped you? So the way the study was designed is that everybody got GAIT analysis. In half of the kids, the GAIT analysis was sealed and put away, so I and the treating surgeons did not have access to that information. And for the other half but we had access to their GAIT videos. And for the other half, we had the full access to their GAIT kinematics, kinetics, and dynamic EMG. Patients and parents were blinded to which group they were in, as was the physiotherapist who was measuring these outcomes at baseline and subsequently. And because it all had GAIT analysis, we could measure GAIT analysis at 1 and 2 years after their surgery. So we could compare the change in GAIT analysis. We measured the GMFM 66, we did the Palsy, the AST, the FAQ, and the FMS. PROMIS didn't exist at the time. And we were going to look at effect size and responsiveness, et cetera, for all these measures so that we could pick which one of these would be our definitive outcome measure. Well, I'd ask these kids, do you think the operation helped you? Some of them would say yes. And when they said yes, I'd say, well, how? Because I didn't want to put words in their mouth. You know, of course, I'm pleased to hear that these operations help them. And they say, well, I walk better. Well, I would push further and say, well, what does that mean? And they started to say things that, you know, made sense. Okay, they tripped less, they were walking further, they had no pain, or they found that they were able to do certain things that they couldn't do before. Or certain activities like biking became a lot easier. Okay? And other kids said, yes, it helped me here, but I lost something else. So we would do a distal femoral extension osteotomy, which is an operation to correct somebody's crouch. And they were standing up taller and would effectively weight bear for transfers more effectively, even take some steps. But previously, they got around independently at home by knee walking, and they had lost that ability to do so. So they'd made some gains in one area and lost a very important functional skill right here. And this led me to think about, my goodness, a lot of these things that they're talking about were simply not being captured by any of these other outcome measures, even when you put them all together. Because again, nobody had actually bothered to ask children and parents why they were doing these operations. So let's go back to David and ask the question, what did David actually want? Well, he wanted to get rid of his knee pain. He was frustrated about getting tired easily. He wanted to go out and keep up with his friends. He wanted to play more. And he was spending, his parents invested a lot of time, effort, and even money to put him in therapy during the summer months when his brother was out in camp. And he didn't, you know, David wasn't that keen on doing therapy. He wanted to do less therapy. Of course, he wanted to trip and fall less. He wanted to get rid of his braces. He realized that his braces were helping him, but he didn't like wearing them because it they made him feel and look more different from others. He wanted to look less different from other people. And when you asked him what it would take to do that, he said he wanted to stand up taller, he wanted to get his heels down, and he wanted to stop his intoing. And parents, of course, wanted David to rely less on walking aids and to preserve his independence. Very laudable goals, and we do need to get the parents' perspective that maybe, looking at things much more into the future. But and sometimes they're the same as their child, and sometimes they're quite different, and we need to reconcile those. So when we do an intervention for kids with ambulatory cerebral palsy, Mercer Rang, who was one of my mentors, another pioneering pediatric orthopedic surgeon who spent a lot of time looking after kids with cerebral palsy, he said after the intervention, the child walks differently, but does the child actually walk better? And that depends on how you define better. You know, is it better on the basis of the body structure and function or impairments, or based on the GAIT analysis, or is it based on activities and participation? It should be, we can agree, based on outcomes that are meaningful to patients and parents. Things that, if you think about it, you know, reducing pain, increasing walking distances, improving mobility, making them more physically active, participating more in sports and recreational activities of their choice, improving the appearance of GAIT, improving their fitness and endurance so they get less tired, more stability, less tripping and fewer falls. And again, like I said before, some interventions might be preventive rather than to improve something. That's then, you know, shed light on the imperative then to go back to the drawing board. I'd assumed that there was a need for level 4s and 5s at the severe end of the spectrum, but it turned out that even for levels 1, 2, and 3, for ambulatory kids with cerebral palsy, there was something missing. So we interviewed children with CP and their parents who were about to undergo various interventions, whether it was serial Botox and orthotic adjustment or a new orthosis or multi-level surgery or an SDR, and asked them, what are your priorities and goals, and what are the things that you want from these interventions? We use the same priority framework that I talked about in my previous talk to understand what their goals are. And we interviewed a whole number of patients and parents, as well as healthcare professionals who look after these patients from multiple disciplines, both surgical, medical, and from therapy and orthotics from around the world. And together, this work led to the initial version of the GAIT outcomes assessment list, which we then tested on on an additional cohort of children and parents, and further healthcare professionals to come up with the final version that comprises of 48 items distributed over these 7 domains. The domains include independence and activities of daily living. So the kinds of things that allow someone to be independent and do the things that are necessary in the daily life. Things that are related to gait function mobility. Items related to being free of pain and being not fatigued. So things like comfort and endurance. Physical activity, sports and recreation. What it looks like is immensely important for parents and for some children, or for some children at certain times more than others. The use of walking aids and braces and body image and self-esteem. And very similar to the CP child, for every item, we then asked how important that item was for the respondent. And we asked them, is making a change in this item an important goal for you? Okay, so that was sort of the structure of the questionnaire, where for the first domain, which are tasks related to activities of daily living and independence, you can see what these are from 1 to 9. We find out either from the child, who we can ask directly from the child version, or the parent who responds from their perspective, how easy or difficult that task is, from being almost impossible, extremely difficult, to no problem at all, and how much assistance is required to achieve the task, from total assistance to being independent. So a child might say it's easy, but they require some supervision. So they would get a score of 4 plus 2, 6. Another child may say easy and it's done independently, so they'd get a score of 4 plus 3, 7. Another child might say it's difficult, but they do it independently, so they would get a score of 2 plus 3, 5, and so on. And then they get to report whether making a change in that item, which is getting in and out of bed, is that something important, a goal for them to improve on at any given time. Similarly, for the task related to gait function mobility, these are things that you can think about: walking long distances, getting around indoors, at school and at home, walking for longer periods of time, walking faster than usual, stepping around or avoiding obstacles, going up and down stairs, going up and down slopes, walking on uneven ground, walking on slippery surfaces that are wet or icy, how easy or difficult it is, and what walking aid they require to do it. Are they using a wheelchair to walk these distances, but only a walker for getting around indoors and at home, all the way to independent of any walking aids? And again, is making a change in each of these, or improving their performance, this is an important goal for them at any given time. Pain, discomfort, and fatigue. You can see pain, the way they conceptualize this, well, at different levels, at the foot and ankle, in the lower legs, in the knees, or the thighs or hips, in the back, feeling tired while walking, feeling tired while doing other physical activities that they usually enjoy, such as recreational activities and sports. And again, the frequency of that symptom, from every day to none of the time, and the intensity of the system, which is edited. So you capture both the frequency and the intensity of the pain or the fatigue. And again, is this an important goal for them to improve? Physical activity, sports, and recreation. It turns out that running is a very different sport from a gliding activity like skating or skiing or snowboarding, which is completely different, uses different muscles, a different skill set than a riding activity on a bicycle or a tricycle. Very different from swimming. Very different from sports that require running, that requires sports that require jumping like basketball or volleyball, or sports that require balance like dance or gymnastics or martial arts, or climbing activities. And these are the kinds of things that many of these children do, either with or without adaptive equipment, and things that contribute hugely to their quality of life, but very different from walking. Okay, and again, notice that in every domain, there's the opportunity for them to add additional items. And here, how easy or it is to difficult, or difficult it is to accomplish that task. And if they've not had a chance to do the activity in the past year, they can report that. And again, is making improvement in this in each of these an important goal for them. The GAIT appearance came down to the issue of the theme of wanting to look less different from other people. But as children see it, they want they want to walk with their feet flat on the ground primarily for that reason. I, as a surgeon, may want to do it because I want more stability in stance phase to prevent them from tripping. And indeed, the kids may want it for that reason as well. But another important reason is because it makes them look less different from other kids. Walking taller, walking with their feet pointing straight ahead, walking without dragging their feet, walking without tripping and falling, wearing footwear of their choice. Symmetry was also an important a goal for some of these kids, which may not be achievable in someone who's hemiplegic. And again, is this an important goal for you? The use of walking aids and braces, how happy or unhappy they are to use these, even though they may be helpful for them, and is reducing their use and eliminating it, those walking aids and braces an important goal for them. This is not to make a judgment about whether using them is useful or not. In fact, many of them are incredibly empowering and useful, but some children don't want to use them, and some parents would like them to use them less. Body image and self-esteem, which also captured this issue of symmetry, how happy or unhappy they were. Okay. When we then tested how important these items were for children and parents, we found that, again, this is the parents' perspective in red and children's perspective in blue. All of these items were on average more important than that threshold of at least slightly important from 0 to 5, which provided us some face and content validity for the items in the goal questionnaire. You can also see that the parents and the children are, although they are very different, they're very closely correlated. But the parents are consistently rating every item as more important than the children rate themselves. Okay? And when you break this down to each of the domains, you can see that the parents consider each of these domains on average more important than their respective children do. But the direction of those correlations are identical. And again, this is not surprising. These children were born with CP. This is their normal, and they're more accepting of their circumstances. And parents impose their value system. They're comparing their child to other children, to siblings, and so on. And therefore, the impact is perceived by parents to be more than perhaps children perceive themselves. Now looking at the actual comparison of the actual scores from 0 to 100 for the total score and for each of the dimensions, again for 0 to 100, for children and their parents, you can see there are significant differences between children and parents for the total score and every one of those dimensions, except for the use of braces and walking aids. And in every instance, the relationship is identical. Parents rate their children on average 10 points lower than children rate themselves, even though there's a very high correlation between their scores of 0.85, which is highly significant. The parents consistently rate their children lower than children rate themselves for the reasons that I shared with you. And the goal scores demonstrate, however, no floor or ceiling effects. If you look at the range of scores, again, from the teens to the high 80s, with an average or mean score in the 60s for children and in the mid-50s for parents. Again, a nice distribution of scores. When we tested the retest reliability for children and for parents, 2 weeks apart, when they reported no change between the two administrations, you can see the ICCs very respectable, both for children and for parents, at the first and second administration for the domains as well as for the total scores, with very respectable ICCs, even for the child scores. When you look at the internal consistency using the Cronbach's alpha, again, excellent internal consistency for children's goal as well as the parents' goal across all the different domains. When we tested the construct validity, we hypothesized that the goal score should decrease by increasing GMSS level. for children as for parents, and this is exactly what we saw. With increasing GMSS level, the goal scores significantly changed from level 1 to level 3, from level 2, and level 2 to level 3 for children and for parents. And we also compared this with a control group of idiopathic tour walkers, and noted that idiopathic tour walkers, both the children and their parents, on average, scored higher on the goal score compared to on the goal questionnaire compared to children with cerebral palsy, both quite consistently. Again, providing some construct validity to the goal questionnaire. When you look at the effect of GMFCS on the domain and total scores, you could see that this change based on the GMFCS was most noticeable for the domains of ADL and independence. The level 1s scored higher, and level 2s scored higher than level 3s. Similarly for gait function mobility, but not so much for comfort and endurance. There was not much of a difference between the 3 GMFCS levels, nor for body image and self-esteem, or even the gait appearance. So just because you're more severely involved doesn't necessarily mean your self-esteem is worse than for someone who functions at GMFCS level 1, which is also an important observation for us to make. We then validated this in a combined project with our colleagues in Melbourne, published by THOMASON in DMCN, where we did a prospective cohort study of over 100 children, boys and girls, GMSS 1, 2s, and 3s, where parents completed the goal questionnaire, the FMS and FAQ, when these kids attended the GAIT lab. In 90 of them, they'd had the GAIT analysis as well, so we could get the GAIT profile score and GAIT variable score. And we were then able to look at the goal scores in this population. Once again, this is the parents, of course, a mean score of around 60 on a scale of 0 to 100, with a wide range with a nice wide standard deviations around that mean for the total as well as the domain scores. When we compared these scores from level 1s, 2, and 3, the same relationship that we showed in Toronto that was quite significant, showing discriminant on known groups of validity. When we compared the goal questionnaire with the FAQ, you could see that the correlations with the FAQ were very quite high, 0.75, 0.77, with the FMS about 0.6 to 0.66. Again, those are the kinds of correlations you would expect. And remember, the FAQ and the FMS are only scratching part of the surface of the problem and are not holistic like the goal are. When we then compared the total goal score from 0 to 100 on the y-axis to the GAIT profile score, so an increasing GAIT profile score is an improving GAIT score based on GAIT analysis, you could see as the GAIT profile score was less different from normal in this direction, as the GAIT profile score increased in this direction, which means the GAIT is deviating more from normal, the goal scores decreased with a negative correlation of, again, 0.66 that was clinically significant. So we know that the goal questionnaire has content that reflects the priorities of ambulant children and their parents. The goal is reliable, its domains are internally consistent, it demonstrates construct and convergent validity, both where it was developed and internationally. It has a wide distribution of scores that are free of floor and ceiling effects, and it has the potential to serve as a more meaningful goal-based outcome measure for gait-related interventions for children with cerebral palsy, provided we can show that it is sensitive to change and that work is ongoing. But when we think about patient-reported outcome measures in general, we know that PROMs are the preferred way to measure outcomes of effectiveness. And that is why Christy and Nicole Morrow in their work are also using patient-reported outcome measures. PROMs must be relevant and important to patients and parents, so you should choose the ones that are relevant to them. The content must be derived from and include patient and parent perspectives like we've done in the goal, and the completion of the PROMs, we must acknowledge, does impose a burden on the respondent. The 20 minutes that it takes to complete the goal questionnaire, the CP-GMEM questionnaire, you've got to ask the question, is that burden justified? We justify it because, this is the recommended way we need to do it for research, and it provides good evidence that the interventions are making a difference. But what's in it for the patient or the parent? When they complete these questionnaires and invest that 20 or 30 minutes, it doesn't change their own personal outcome after the intervention. And it's a burden. We've got to acknowledge that. So how can we make these patient-reported outcome measures more useful to patients and parents? Can we actually leverage these PROMs to be used to guide decision-making in cerebral palsy? So one of the unique features of the CP-GMEM and the GOAL questionnaire is this feature that they both elicit the perceived importance of the items and whether making a change in each item is an important goal for improvement. Now, while we did that for validation purposes to ensure that the content was relevant and important to the population, we've retained them within the main structure of the questionnaire. And can we leverage those questions? Is making a change in this item an important goal for you? So, for example, in the CP-GMEM, is eating and drinking or being fed in the usual way it's being done? Here's your score. Is making an improvement in this item an important goal for you on a scale of 0 to 2? And feeding is very important, but maintaining oral hygiene is for this particular parent is not particularly an important goal. Bathing and washing is an important goal, as is toileting activities. In other words, they're having difficulties in this area, and this is something they would like to address with your next intervention. Similarly, for the GOAL questionnaire, the activity is getting in and out of bed, how you're doing. It's very easy, and it's of moderate level of assistance, but it's an important goal for the child or for the parent. Maybe they want to decrease the amount of assistance required so the child can do this very easily, but more independently. So we are in the process right now developing an electronic web-based version of the CP-GMEM and the GOAL questionnaires, which on the completion will instantly generate a summary report for patients and parents that will provide not only the total and domain-specific scores, but will also generate a list of items that the parent or the child, depending on whether it's the parent version or the child version, the list of items that they've identified as important goals to address within each domain. And the software will then ensure the compatibility across different platforms and electronic health record systems. So, for example, the e-goal will be completed, or the each CP-GMEM will be completed prior to a clinical encounter. The summary report would be something like this, where you would get the score on each of the domains and the total, which in and of itself may not be very useful to the patient or the parent, but could be indexed to how they did 6 months previously or 6 months in the future to see whether there are changes, and they could create a dashboard looking at the trajectory of these outcomes where the children are compared to themselves. However, complementarily, they can also submit, when they complete the list of items that were identified as important goals for them. And this list is something they can bring to the clinician and say, what are you going to do about this? Okay, so for example, in GILLETTE, this is how it's presented. Here's a GMFCS level. They are using our version of it. These are the scores. And again, this is a child in the GMFCS level 1. And here they have indexed it to other children GMFCS level 1, so they can provide a percentile score for that particular child in this particular circumstance. I think it's quite appropriate. But it also then allows them to generate the list of those items that I talked about, which can then focus the therapists or the orthopedic surgeons or the neurosurgeons or the physiatrist's attentions on what we should be addressing. So can PROMs be designed to elicit patient goals? Can we use the PROM both as an outcome measure to elicit as well as to elicit patient priorities and goals? If we can do that for patients and parents, it empowers them to articulate their priorities and goals. It might reveal differences between patient and parents or between parents. For clinicians, it can be an efficient way to comprehensively identify patient-parent priorities and provide the opportunity and responsibility for us to respond to these. And the value of such a PROM will extend beyond its utility just to track outcomes for research. It might facilitate decisions about whether to treat and when to treat. It might support or guide the choice of intervention tailored to the goals. It may help us manage expectations if we can identify goals that may not be feasible or realistic at this time. And it might improve the process of informed consent and can improve shared decision making. Of course, we need to prove the clinical utility of these features to address these things. And indeed, in order to justify incorporating these in our electronic health record, And it's part of personalized or precision medicine, where we can consider these PROMs as a way to elicit personal preferences and priorities. So CIHR and the Strategy for Patient-Oriented Research, which is the Canada's equivalent of PCORI, and CIHR is Canada's equivalent of NIH, has sponsored this multi-centered study to answer this question. What's in it for patients? It involves the CP Research Network across the United States in multiple centers that you can see here, including our partners in Australia. We've got parent partners on the investigative team as co-principal investigators and various disciplines, both medical and therapy involved in multiple institutions around in North America and in Australia. So once again, I would say the effectiveness of our intervention should be judged using meaningful outcome measures that reflect the goals and expectations of individual patients. They should be patient reported. They need to be relevant to these populations. We can measure important change by using measures like that have been developed in this particular way. And we now have the means to find out whether our interventions are making a difference, like I mentioned previously. Perhaps we now also have the ability to make these clinically useful for patients and parents as well, to empower them and to guide and support shared decision making. So I would like to conclude by sharing with you sort of our the link to our website, where we've used the priority framework to develop other measures, including the MD Child for muscular dystrophy and other neuromuscular conditions, and so on, that might be relevant to some of your interests. And again, I'm very grateful to the funders of this work and to the large team of investigators that were involved for the CP Child and for the GOAL measure, both in Toronto and our partners in Melbourne in Australia. Thank you for your attention, and I look forward to answering your questions.
Thank you so much, Dr. Narayan. I have some questions already from our audience. I'm going to share them on the screen here. And just for a reminder for folks, there is a link at the bottom below the Vimeo player if you want to submit your questions. So what is your feeling about the, oh, I'm sorry, this is a question from our previous talk. I guess maybe you could answer this question. What is your feeling about the effect of push-off in gait training when wearing orthotics with stiff plastic forefoot?
Sure. So in typically developing children and adults who walk, your push-off is the source of about 50% of your power of your gait comes from that very powerful part of your gait cycle. In children and persons with CP, push-off is relatively weak, and the majority of the power is actually coming from lift up, coming from your hip rather than from push-off. So for those children who are capable of push-off, then of course losing that source of power would be a detriment. So if for the selected child who does have the strength to stand on their tiptoes and push off to propel themselves forward, then taking advantage of that, using an orthotic that allows some controlled plantar flexion during stance phase, the end of stance phase and pre-swing, that still allows them to spring back to keep them less plantar flexed during swing phase, so they can clear the foot, so they're not dragging the foot, would be a useful addition. However, when studies, including GAIT analysis, have looked at comparing the difference between the effectiveness of these different kinds of brace and these features, GAIT analysis has not really shown much of a difference. Now, that could be because it's not sensitive enough to pick up meaningful differences. It still may be valuable, but that remains to be proven.
Our next question. Are there any studies about the mental benefits of moving for CP patients? Suggestions in the US, it is hard to get Medicaid and insurance to approve, and there's not enough data to consider that it's experimental.
I'm going to guess that this has to do with perhaps the potential for untested treatments that are experimental because they've not generated any evidence yet, that may come to parents' attention, that promise the possibility of improving the mobility of children who can't walk. And because improving someone's mobility can be incredibly empowering and maybe have some mental health benefits. What evidence is there to justify doing these experimental treatments? It's a very complicated question that has mixed up in this the idea that parents want to do what's best for their children. They want to leave no stone unturned. One of the most important coping strategies that they have at their disposal is the power of hope. But that same power of hope also makes them vulnerable to all kinds of promises that may or may not be come to be true. And unfortunately, out there in the world, there are promises made about treatments that may or may not be true. And parents may or may not know that that's true. And indeed, the researchers may or may not know it's true, which is why it's important to keep an open mind and research these in a proper way so that, time and effort and travel and thousands of dollars are not being wasted. On the other hand, we should be paying attention to things that might have this potential. Could it have mental benefits? Of course it could, because but on the other hand, we can't necessarily make those assumptions. I would argue that many people choose when they are young adults to use a wheelchair. Even though they can walk, they find that the effort involved in walking exceeds what is worth it. And by using a power chair, it frees them up to be employed, to go out in the community, to keep up with other people, and they don't see that as a failure. And society somehow sometimes does. So we need to consider, what individual people want as well. So it's a long-winded answer, but there's lots to unpack in that question.
Definitely, and I guess it goes with this question: how do you deal with conflicts between the parents' goals and their children's goals?
That's a great question, and one that we should be doing even if we don't have the goal questionnaire or something equivalent. We should be asking children what they want, and we should be asking parents what they want. Of course, parent wants what's best, and sometimes those merge, but sometimes they want very different things. I have children who tell me, I'm happy the way I am, and I need to listen to them, and we need to allow the parents to listen to them as well. On the other hand, many parents have a much longer view. They have a much more mature view of what might happen in the future, whereas a child may be just thinking of what they're undergoing in the present, which is why there's also an important role for the healthcare professionals' goals, because remember, parents and children have only seen what they've experienced, or they've experienced only what they've seen up to that point in time. As healthcare professionals, we've been exposed to other children like them who have, so we've got, and we may know what might be happening in the future as well. So it's really a shared decision where all those perspectives are important, and we need to reconcile those differences so they can come to some common understanding. So this is not to say that children's goals always trump parents or vice versa. We need to recognize that they're both important, and they may not be the same, and therefore we need to know that, and it can be eye-opening. Parents, for the first time, might discover certain things about their children that they had not, that they were making assumptions about, and vice versa.
Thank you so much. Let me move on to the next question. Can you talk about the selection of ITW as a control group?
Idiopathic toe walkers. Okay, that's a very good question. All we were trying to do was, we know that the goal questionnaire was developed for children with cerebral palsy. And when we were testing it, there is one way to test the questionnaire is to see, does it behave in the way we would expect it to behave for the population of kids with cerebral palsy? And for ambulatory cerebral palsy, there's GMS is level 1, level 2, and level 3. But remember, kids with levels 1, level 2, and level 3 with cerebral palsy don't just have walking issues. There are other things that are going in their life, from learning issues. They maybe have upper extremity problems that may or may not be of importance to them. The cerebral palsy affects the brain, and walking in ambulatory cerebral palsy is not the only impact. Whereas idiopathic walkers is a group of children who walk on their tiptoes, do not have a neurologic diagnosis like cerebral palsy, and are functioning without any difficulties. They don't use any walking aids, they're running, playing, and doing everything they want to do. And so, but in many respects, resemble how some kids walk with cerebral palsy who walk with their tiptoes without some of the additional features of cerebral palsy. And therefore, if the GOAL questionnaire is doing its job, maybe it would show that they would have a higher sort of functional score than kids with cerebral palsy. And indeed, we showed that. That was the purpose of it. It's not intended to suggest anything else. It was not intended to be used for idiopathic toe walker, but it was part of this experiment that we have to do during the development of a measure to establish that our measure is measuring what we think it's measuring. We call that construct validity. And we use known groups of different abilities to try and show that what the measure can distinguish between those two groups.
Great, thank you so much for that. And then, are you aware of any evidence or research showing that effective, regular, early physical therapy and optimal orthotic alignment results in fewer orthopedic procedures later in life?
If the question is on fewer orthopedic procedures later in life, I think the short answer is no. But that does not mean that effective, regular, early interventions and physiotherapy is not, and the use of orthotics is not important. Remember that all our interventions currently are not addressing the primary problem, if you will, which is in the brain. That's permanent, and we don't yet have a way of reversing that. We are addressing the peripheral consequences of that. And our different disciplines are addressing different facets of the impact. So your tone management strategies like botulinum toxin or SDR or background pumps are addressing the tone problems. Therapy's effect is addressing the strength or lack of strength or power, as Christie's work is so beautifully illustrated that she's researching on. Orthotics are providing support for joints that are otherwise weak and don't have sufficient support. Orthopedic procedures are addressing the bony deformities and the joint instabilities and the fixed contractures that are not addressed by tone management. So these are different facets. So we should not be seeing these as PT versus orthopedics or orthopedics versus SDR. These are all complementary. Ideally, we'd like to avoid surgery in all these kids, but sometimes kids may need multiple types of interventions for them to achieve whatever their highest potential related to their goals might be. Okay.